Greetings again, everybody. We're going to talk here about how we approach the GI bleed. Primarily here we're talking in an emergency setting. However, there are times when patients will come into the office with a GI bleed, particularly when it's melena. So some general principles of GI bleeding. The bleeding can occur from anywhere. So theoretically, it can occur from the oral mucosa to the anus. So usually when we talk about when something is an upper GI bleed versus a lower GI bleed, the technical definition is whether the bleed originates before or after the ligament of Treitz, which, if you remember, the ligament of Treitz is where the duodenum is attached to the wall. So usually we don't know if it's an upper or a lower bleed because we don't know the exact location of the bleed when the person presents, but we can get a pretty good idea based on the presentation. So the overt presentation is going to vary. Hematemesis is vomiting of blood or coughing up of blood. I suppose not coughing up of blood, but vomiting up of blood. Hematemesis, that is always going to be an upper bleed. Melena is the dark black tarry stools. That tends to be an upper bleed, but it is not necessarily an upper bleed. Maroon stools tend to be more lower bleed than upper bleeds, and bright red blood per rectum is almost always, 90% of the time, a lower bleed. So the stool color doesn't always tell you where the bleed is. Certainly if you have a fast enough upper bleed, you can get red blood in your stool. But the idea is that the longer the blood is in the GI tract, the more it's going to be oxidized, and therefore the darker it will be. So melena tends to be higher than maroon, which tends to be higher than bright red blood per rectum. But if you have a fast bleed, you can get more red blood in the stool. So this is sort of a rule of thumb. It does not tell you where the bleed is coming from necessarily. In order to get that, you need to base it on your symptoms and presentation and history. So as far as management, all patients with a presentation of severe GI bleeding, and I'll explain what that is, should immediately be treated with fluids and worked up for anemia and coagulation problems. So severe GI bleeding is always going to be hematemesis. So hematemesis is always going to be considered severe GI bleeding. Any kind of ongoing GI bleeding, so if the patient has ongoing bloody diarrhea, and then if the patient has hemostatic problems, so or orthostatic problems, so if the patient is running a low blood pressure, if the pulse is high, if they're showing that they're becoming volume compromised, then that's definitely considered severe GI bleeding. So base it on the symptoms: hematemesis, ongoing, or circulatory symptoms. All patients with a history of liver disease, alcoholism, or patients who have hematemesis should be getting IV octreotide. And we'll talk about why that's important. So keep in mind, if it's severe GI bleeding and if the patient has a history of liver disease, alcoholism, or hematemesis. And of course, history is going to give you significant hints to the likely diagnosis. There is a myriad of possibilities when a patient comes in with GI bleeding, but the history and accompanying symptoms should help you focus in on what the actual problem is. But the emergency management is, in general, going to be the same. So here's some vignettes. These are all patients with these are real patients. They're all patients, though, with different disorders, but they all have GI bleeds. So a 27-year-old man is brought by his concerned friends in the middle of the night after his bachelor party because he was seen to be vomiting blood. A 57-year-old woman presents to the ED after having vomited blood this morning. She has a long-standing history of GERD, which has been refractory to therapy. She is also a 40-pack-year smoker and an alcoholic. A 63-year-old man is brought by EMS after an episode of vomiting blood. He has had another episode since arriving at the hospital. He has a history of alcoholism, and his blood pressure is 90/55. A 59-year-old woman presents to the ED after having an episode of bright red blood in the stool this morning. She also complains of abdominal pain, primarily lower and left-sided. She has no other contributory history. So you could consider probably the top three, the first three of these to be severe bleeding. The first two because you've got vomiting blood. Well, actually, all three of these because you have vomiting blood. The last one probably wouldn't be considered severe because there was one episode and it's not ongoing. Okay, so emergency treatment of GI bleed. So whenever we have a GI bleed that is severe, so when it's hematemesis, if it's ongoing bloody diarrhea or ongoing blood in the stool, and if there's a low blood pressure or if there's orthostasis, that's always considered severe GI bleeding. So hematemesis, ongoing, or blood pressure changes. Then the first thing you're going to do for this patient is you're going to give them an immediate bolus of normal saline. And the reason we do this is because no patient was ever killed with one normal saline bolus, or at least not that I've ever seen. And anytime you've got a patient that's bleeding, that's losing fluid, you definitely are going to know that this patient's going to benefit from getting fluid back into their system. So fluid is necessary for patients that have ongoing or severe GI bleeding. In the meantime, if the patient has hematemesis or they have a history of liver disease or alcoholism, which is something that you should either see or you should be asking them or looking in their charts, then you should also administer IV octreotide. And the reason is because in patients who are bleeding or who are vomiting up blood, or they have a history of liver disease or alcoholism, one very probable or possible cause is gastroesophageal varices, which I'll explain in a bit. But with varices, this can be a severe life-threatening disorder. And so octreotide is a vasoconstrictor, and it will, in most cases, reduce the severity of the hematemesis, if the cause is indeed varices. As far as labs, the most important labs to get initially are an EKG, a CBC, and a PTT and PT. So we want to make sure that there's no cardiac issues going on here. That's always good to cover your butt. CBC is going to be good to check if there's any kind of anemia going on, and then also to check the platelets, of course, too. And then PT and PTT are important to see if there's any kind of bleeding that's due to factor deficiencies. So we want to make sure that the patient is not anemic, and we want to make sure that the cause is not due to a platelet deficiency or to a factor deficiency. And then we're going to want to have the blood type on this patient and cross-match. So in case we need to administer red blood cells, then we know what type to give them. That's always going to be important in a bleeding patient. If the patient has a low hemoglobin on their CBC, you're going to administer packed red blood cells. That's common sense. Usually, you can set the cutoff at a hemoglobin of 10. If they're below 10, then you should go ahead and administer packed red blood cells. And the reason we set it at 10, which sounds a little high because we wouldn't necessarily think anemia at 10, or at least severe enough to give red blood cells. But when a patient has a hemoglobin of 10 and they're losing blood, then you should administer packed red blood cells now rather than waiting until they become symptomatic. And certainly, if the patient is older, then you could even set that cutoff higher. But 10 is usually where we set it. If the patient is younger, you might be able to get by setting it lower. But 10 is a safe number to go with as far as administering red blood cells. As far as platelets, if it's below 50, then we're going to go ahead and transfuse them, and that goes for pretty much anybody. So 50,000 platelets. And if there's an elevated PT or PTT, then you'll go ahead and administer fresh frozen plasma. But in all patients with severe GI bleeding, they're going to get fluids. And if it's hematemesis or the patient has a history of liver disease or alcoholism, you're going to give them IV octreotide, and then these labs are going to be ordered. So some of the various causes of upper GI bleeding are peptic ulcer disease and gastritis, which we talked about in its own section. The Mallory-Weiss tear is an esophageal disorder. Gastroesophageal varices, gastric or esophageal cancer, and esophagitis. So let's talk about each of these one by one. We're not going to go in depth. These are all talked about in their own sections, with the exception of varices, which I'll talk about here. So peptic ulcer disease, this is usually associated with a gnawing pain, a pain that's generally in the middle of the abdomen, so it's not very easily localized. It tends to be the patient will usually point to their belly button, or they'll point to the midline, or maybe slightly to the left, but it wouldn't be necessarily in any quadrant. So this is associated with gnawing pain. It's associated with NSAID use and certain other disorders. A lot of patients who have bleeding associated with peptic ulcer disease will have had a history of peptic ulcer disease in the past. So this usually won't be their first presentation with peptic ulcer disease. For gastritis, they tend to present very similarly to peptic ulcer disease, and that's just simply because most patients who have peptic ulcer disease developed it from gastritis. These patients also have that typical gnawing pain. It's not a burning pain. It's more of a dull, achy pain. And this is also associated with NSAID use, but you can also get acute gastritis from alcohol and tobacco. So both peptic ulcer disease and gastritis can be associated with upper GI bleeding. They can present with upper GI bleeding, but peptic ulcer disease may, but gastritis usually will not present as frank hematemesis, but it could. So the next one, though, is Mallory-Weiss tear. This will always present, it's defined as hematemesis. So the Mallory-Weiss tear we talked about in the esophageal disorders, and this is a unique disorder in which the patient has retching. They have ongoing vomiting, and usually gets to the point where they have dry heaves, and then all of a sudden they'll start vomiting up blood. And what the Mallory-Weiss tear is it's a superficial tear at the esophageal stomach junction. So right at the distal part of the esophagus, you get a tear, and it's not a deep enough tear, but it's to cause a perforation, but it's a tear that will cause bleeding, and so the patient will then begin vomiting up blood. As far as gastroesophageal varices, these are associated with alcoholism and liver disease, and this is also going to present as some acute hematochezia, or hematemesis, but this is much more significant than Mallory-Weiss tear. Gastroesophageal cancer tends to have a history of refractory GERD, alcoholism, tobacco use. And then esophagitis will usually be GI bleeding on a patient with a history of odynophagia. And then rarely is aortoenteric fistula, and this is in the patient who is status post abdominal aortic aneurysm repair. So this is where you repaired the aorta and it develops a fistula into the esophagus, and obviously this is another very, very emergent condition, but it's quite rare. Okay, so what are esophageal varices? So esophageal varices are due to liver disease. So anything that causes cirrhosis of the liver, which includes alcoholism, can cause varices. So normally what happens is the circulation, the venous circulation from the esophagus and the stomach, about 90% of it will drain directly into the inferior superior vena cava. But about 10% of it, the veins from the esophagus and the stomach, will drain to these superficial veins. And these superficial veins ultimately drain into the portal vein. So you have your stomach veins that drain into your splenic vein, which drains into the portal vein. And then you have your superficial esophageal veins, which drain into the portal vein directly. Now, your portal vein has to go through your liver. And if your liver is cirrhosed, then as the portal vein goes into the liver and it goes into your really tiny, all those tiny little sinusoids, things are going to get congested because the liver is chronically inflamed. And so because you have that congestion in the liver, blood moves slower. And so because blood moves slower, the pressure in the portal vein is going to be increased. And because you have that portal congestion, or what we know as portal hypertension, what's going to happen is you're going to get blood flow that's going to be moving through accessory veins in the esophagus and in the stomach that will route it directly to the inferior or superior vena cava. Unfortunately, those veins are not made to deal with that kind of traffic. And so the veins can become distended, and when those veins become distended, that's what we call varices. They're distended veins. The problem comes when those varices rupture. So basically, the way to think about it is you have traffic on the freeway, and the traffic got really bad because of a car accident. Think of the car accident as liver cirrhosis. And so now everybody's going to have to get off the freeway in order to get to work, and they're going to have to get on the residential roads or the low-frequency highways. And those roads aren't made to deal with that kind of traffic. And so what happens then is you've got blood moving to the inferior and superior vena cava via accessory veins, and those accessory veins become engorged. That's when it becomes a varice, and then it's prone to rupture if the pressure gets too high. And that's when we have a variceal rupture. So you can have varices, and those aren't necessarily bleeding, but once the pressure gets up high enough, they can burst. And that's when we have a problem. So how do we treat the upper GI bleed? Remember, in all cases of severe GI bleeding, we're going to be giving fluids. In cases where we think it might be an upper GI, or where we may think it's a variceal bleeding, we're going to give them octreotide. As far as labs, we get EKG, we get CBC, we get PT and PTT, and at that point, then we should make sure that the patient then is stable. After that, then, patients with a history of peptic ulcer disease or gastritis, regardless of what they're in there with, regardless of their other symptoms, they should be given an IV or PO proton pump inhibitor. So if a patient has peptic ulcer disease or gastritis, if they have a history of that, more than likely the cause is going to be a bleeding ulcer. So we give them a proton pump inhibitor as sort of an empiric therapy. If they have acute vomiting, or if they've been vomiting in the ER, give it IV. If they've not been vomiting, if they've been stable, you can give it PO. It never hurts to give it IV, but we tend to prefer PO if we can give it in that manner. Patients with refractory hematemesis, after you've had them in the hospital, then you should do an endoscopy. An endoscopy is the most accurate test to determine the etiology. So if you have a question that says, that gives you a vignette of an upper GI bleed or a lower GI bleed patient, and it says which of the following is the most accurate test in the diagnosis of this patient, even though it's not going to necessarily, it's never going to be the first step, endoscopy is the most accurate test for diagnosis. So endoscopy is good because as far as upper GI bleeding, it will allow us to locate the source. And if it's varices, what we can do is we can go ahead and do therapy with the endoscopy. And that therapy is going to be variceal band ligation. And that's where we take the bleeding varice and we ligate it so that it doesn't bleed anymore. So we can do that by endoscopy, and that is the treatment of choice if an active variceal bleed is found. Now, the first thing we do for patients where we presume possible variceal bleeding is going to be octreotide. But if they're not responsive to octreotide, and I'd say about 1 in 5 patients are not, then we go ahead and do endoscopy and we do variceal band ligation. Sclerotherapy is another option, but it is not the treatment of choice. So variceal band ligation is the treatment of choice for octreotide resistant or octreotide refractory variceal bleeds. If the patient has hematemesis that's refractory to the band ligation, then you can go ahead and do a transjugular intrahepatic portosystemic shunt, which we call TIPS. And that is sort of a surgical technique, and I'll show you what that looks like on the next slide. All patients who have been diagnosed with esophageal varices should be, after discharge, on daily propranolol, and that's because it will reduce the pressure in the veins. Okay, so this is tips. So remember what I said about how in order to get around the cirrhotic liver, the blood will take an accessory route to the heart. And that's because the liver is cirrhotic. Well, what you can do is, if you give tips, what you're doing, you can give an accessory pathway that doesn't include veins that can become variceal. So what you're doing is you're relieving the pressure between the portal vein and the hepatic vein in a way that's not going to mean the blood needs to go through the variceal veins. And so all you're doing is you're putting in this shunt. And this shunt goes from the portal vein to the hepatic vein. So what happens is you normally go from the portal vein into your small veins of your liver, which is normally where your blood gets detoxified, and then you go up to the hepatic vein. What you can do with this stent is you skip right through there from the portal vein to the hepatic vein. Now that's got a plus side and a bad side. The good side about it is that you relieve the pressure at the portal vein, and therefore you're relieving the pressure at the varices. And that's good because it means that it's going to be less likely that you're going to have a variceal bleed. Now, the compromise to that is that you're going to have a lot of blood that's going to be skipping past the liver and going straight into the hepatic vein. And so because you have blood that's going past the liver and not getting detoxified, you're going to have a higher likelihood of hepatic encephalopathy and elevated liver enzymes and exaggerated liver failure. So keep that in mind. But TIPS is sort of our third line of treatment. First line of treatment is octreotide for suspected esophageal varices. Second line of treatment is endoscopy with band ligation. And our third line of treatment then is TIPS. Ultimately, our fourth line of treatment would be surgical. Okay, lower GI bleeding also has a large spectrum of causes. We have diverticulitis, hemorrhoids, infectious diarrhea, inflammatory bowel disease, ischemic colitis, colon cancer, angiodysplasia, intussusception, and then some of the more rare or pediatric causes, which include Meckel's diverticulum, intussusception, neck or necrotizing enterocolitis, and juvenile polyposis syndrome. So we're not going to go into the pediatric causes, but starting with diverticulitis, this classically presents with lower left quadrant pain, usually in a patient that's older and has a history of constipation. Hemorrhoids tend to present as anorectal pain, particularly if it's an external hemorrhoid. If it's an internal hemorrhoid, you won't see a pain in that patient. But these patients also tend to have a history of constipation. They can also have a history of liver disease, and the reason that the hemorrhoids can form in patients with liver disease is for the same reason that you can get variceal bleeding and varices in patients with liver disease. It's just another alternate route for the blood to get back to the heart. Infectious diarrhea tends to occur in patients with other sick contacts, with food exposure, particularly with fever. And this will always be an acute diarrhea. They'll generally be patients who have been healthy up until now, and all of a sudden they've developed a bloody diarrhea. Inflammatory bowel disease is always a chronic diarrhea. These patients will tend to have fever during their episodes, and they may have extraintestinal symptoms. We did a whole section on inflammatory bowel disease. Ischemic colitis will be a very, very, very severe pain, particularly in an older patient or in a patient with something that gives them a predilection to develop an embolism, so a history of atrial fibrillation, for instance. Colon cancer will often present with a change in stool caliber, or it could be a patient with chronic symptoms of anemia. Angiodysplasia is something that really you'll only see on colonoscopy, so there's really no specific symptoms with angiodysplasia, but these patients could have prior diagnosed cases of angiodysplasia. Some patients are just susceptible to angiodysplasia. Intussusception can present as a bowel obstruction, and as far as pediatrics, we're not going to go through those, but just know that they exist. We'll do a special section on some pediatric causes at a later time when we get to pediatrics. Okay, so the further treatment of lower GI bleeds is we're going to give them the same emergency management. When the patient becomes stable, then, and as far as stable, I mean the bleeding has stopped or has reduced in frequency, then we can go ahead and do endoscopy. And it's not unusual that you're going to, in a clinical setting, that you're going to have to do both an upper and a lower endoscopy to find out what the cause of the bleeding is on the patient. Oftentimes with the symptoms, you just don't know in real life. On the USMLE, they're going to give you enough hints to where you know, do I have to do an upper endoscopy or do I have to do a lower endoscopy? And so knowing these associated symptoms is important. So colonoscopy would be the next appropriate diagnostic step in the evaluation of a patient with lower GI bleed, and endoscopy again is the most accurate test in diagnosis. Endoscopy is going to be diagnostic in approximately 9 out of 10 cases, and if you don't find a cause in a patient with endoscopy, if you don't find a cause in a patient with lower GI bleed after you've done endoscopy, there's two things you can do. If the patient is equivocal and you don't know it might be upper GI bleed, you can try an upper endoscopy, and in fact that's what you will normally do in a clinical setting. But as far as the USMLE, if the symptoms, the history is making it really look like a lower GI bleed, then a tagged red blood cell scan is your next step. And what this is you're putting in red blood cells into the patient, and they're tagged with a nuclear marker, a fluorescent marker, and then you take a picture of their abdomen and you can see where the blood is coming out, and that will show you where the bleeding is. And usually it's angiodysplasia that is going to be what's diagnosed from this, because that's very difficult to diagnose on colonoscopy unless you have a very trained eye. And finally, our last-ditch diagnostic test is going to be a capsule endoscopy. And the reason is because upper endoscopy only goes approximately to the ligament of Treitz, the middle part of the duodenum roughly, and a lower endoscopy, a colonoscopy, can only go approximately to the terminal ileum. So the capsule endoscopy is going to help us visualize the small intestine. So to recap, a severe GI bleed, hematemesis, ongoing, or blood pressure changes, always administer fluids. So the first thing on your mind in any patient with GI bleed, regardless of how severe it is do I need to administer fluids? Is this patient severe enough? And you should lean towards, yes, they are severe enough. You should always err on the side of caution. So fluids is going to be the first thing you think of, just like your ABCs. Patients with alcoholism, liver disease, or hematemesis should always be given an IV octreotide. And then your labs are CBC and PT and PTT. That will help you dictate further resuscitative care as far as if you need to give this patient platelets, packed red blood cells, or fresh frozen plasma. You should also get an EKG on any GI bleeder as well. Endoscopy is going to be the most accurate test as far as the etiology, but it's not the first step. And for varices, the steps are going to be octreotide, endoscopic band ligation, and then TIPS, and then, of course, surgery. But remember that order. All patients with varices should be discharged on propranolol for long-term therapy. And that's the end.